Thank you. And welcome, everybody. Thanks for joining today. I'm going to be talking to you about evaluation and management of coronary disease in the primary care setting. So my job is dealing mostly with patients for whom this strategy has not worked. So I spend my days in the cath lab doing angiograms and stents on people with symptomatic coronary disease. What I'd like to talk to you guys about is trying to prevent people from coming to the point that they need those services. So primary prevention of coronary disease is a very well-researched and well-understood topic. We've got a ton of data about what works and what doesn't work. Prevention of cardiovascular disease is a huge public health and economic problem. So there's been tons of resources devoted towards studying it and coming up with really the best strategies. So when we make recommendations for primary prevention of cardiovascular disease, really more than any other field in medicine, we know what we're talking about with data to support the recommendations. That being said, the actual execution of those well-researched guidelines and recommendations and strategies, the real world execution tends to be very mixed and very heterogeneous. So hopefully I can get everybody on the same page with some of the basic guidelines and basic strategies for keeping people healthy. So I'm going to talk about this in 3 different encounter settings. So as primary care providers, there are 3 kind of patient visits that you'll be facing where you'll be addressing the issue of coronary disease. The first one is primary prevention. So a wellness visit where someone comes in and says, hey, I'm feeling okay, but I want to make sure I don't have a heart attack down the road. What can I do? Maybe I've got a family history of coronary disease. How do I stay ahead of the game? And this is where we have a ton of data, and you can really make some solid recommendations and make some positive impacts on your patient's health. I'm going to spend most of the time talking about those strategies. Second encounter type is someone for whom you have some suspicion for anginal symptoms or symptoms of CAD. So the first visit is someone who it's called primary prevention, where you're trying to prevent something from happening. Second case is someone where you think maybe somebody has something going on, and how do you approach that patient? And then finally, the third patient type is someone who does have coronary disease. They've had the diagnosis made. Maybe they've had a heart attack. Maybe they've had a stent or bypass surgery in the past. And now they walk into your office and say, what can you do to keep me healthy, doc? So that is the realm of secondary prevention, which is dealing with a much higher risk patient than the primary prevention population. So primary prevention, what are we trying to do? The goal is to prevent clinical atherosclerosis. At least I talk mostly about coronary disease because that's kind of my bread and butter, but we're really talking about all of the vascular beds. Vascular disease can cause lots of clinical problems. Heart attack, heart failure, sudden cardiac death are the main things we're dealing with in the cardiology realm, or the less dramatic but still lifestyle limiting symptoms of chronic stable angina. In the cerebrovascular bed, we worry about carotid disease and stroke. Peripheral vascular disease causes claudication and can progress to limb-threatening ischemia or even amputation. All of those myriad manifestations all have at their root vascular atherosclerosis. And in most cases, if you treat one with preventative strategies, you're treating all of the vascular beds, and you benefit someone's peripheral vascular disease if you treat their heart disease, and vice versa. So what can we do to people? There's a lot of angst and a lot of patients about their cardiovascular risk, particularly if they've had friends who have had issues or they've got a family history. And they're coming to you to find out what they can do to improve their chances. And there's only a handful of things that actually we have to offer. The most basic is lifestyle changes, and it's kind of mundane, and it's always listed as something you're supposed to do, but it's not a very sexy topic. People don't like changing things, and often it gets kind of brushed by the wayside during patient interactions. But people really can improve their risk profile with basics of diet and exercise. I don't really talk to people about specifics of diet very much. More general recommendations. That's something that is probably more variable from person to person, what advice you give. And we'll go into a little bit more detail about that in a few slides later. And then the big one where you probably have the most bang for your buck for counseling is tobacco abstinence, getting people to not start smoking or really using any tobacco products. And then probably the most impactful thing you can do is get someone to quit smoking. That has a greater effect on their overall lifetime cardiovascular risk than anything else that you can do for them. And then the second class of interventions are more doctor things, prescribing drugs, medications that will reduce their risk of having their first event. And again, this is primary prevention. So these are people who have not had any clinical cardiovascular disease at the time of your visit with them. What you're not using as a primary prevention intervention is revascularization. And this is kind of a point I'm going to try to hammer home, is there's a kind of a impression among patients and among a lot of providers that they want to find the widowmaker lesion, they want to find the blockages that they have that they might not have, because somehow treating that with stents is going to keep them healthy and prevent them from dying from a heart attack. I'm going to show you through the rest of this talk how that really is a misguided goal. We're trying to get people from getting to the point that they need revascularization. And in patients who are asymptomatic, there really is limited to almost no role of revascularization in managing patients who don't have any symptoms of cardiovascular disease. So the current practice of cardiology is very imaging intensive. Our culture is that we want to get procedures done that are going to fix the problems we have. But really in this setting, we want to be focusing on preventative strategies that are as simple as going for a walk or taking an aspirin. So I really like this graphic. This at the top here is a progression of atherosclerosis pictogram, where you're going from a normal vessel at the left with deposition of plaque and formation of a fatty streak and fibrous plaque progressing to a lipid-rich complex plaque. Here we see the complicated lesion, which is a ruptured plaque. And then on the very right hand is a healed calcified lesion that is the sequela of a previous plaque rupture event. And the common misconception among a lot of patients and a lot of providers is that this, if you ignore the plaque here, people are worried, ignore the thrombus. People think that the worse the blockage is, the worse they're going to do. The more chance they have of dying, the more chance they have of having a heart attack. When in fact, the severe, stable coronary plaques can cause symptoms of chronic angina, which, though it does in part increase morbidity and mortality, is not the big killer of people. And what people generally are afraid of is the sudden grab your chest and keel over dead heart attack. And that generally doesn't happen to people who have advanced coronary plaques like this. They tend to have plaque rupture in plaques that are not occlusive. So when we see people come in with an ST elevation MI or a bad acute coronary syndrome, they will often have plaques that are maybe 20, 30, 40% stenotic that have ruptured. And that's what you see in these bottom panels here. You've got a non-occlusive plaque. If this person had a catheterization a week before their heart attack, they would have a mild luminal irregularity noted, maybe a 20 or 30% narrowing on their angiogram. But they've had inflammation within their plaque, they've had ulceration, and they get fissuring of the fibrous cap. When that happens, you get exposure of the lipid-rich core to the bloodstream. And what causes the sudden heart attack is the prompt thrombosis of the coronary artery, taking them from a 30% narrowing to a complete occlusion. That can happen in 15, 20 minutes or so. These dramatic events with rupture of the plaque often occur in non-occlusive non-occlusive lesions. And those are the biggest driver of cardiovascular death and morbidity in otherwise healthy people who have not had previous coronary problems. And so we're not necessarily looking for bad plaques in these people. We're looking for people who are at risk for having plaque rupture. And that's where we get into cardiovascular risk factors. And really the cornerstone of primary prevention for any given patient is to assess their cardiovascular risk. And we've all learned in medical school the standard risk factors. Those risk factors can be quantified and compiled to produce a risk score. And I want to encourage everybody to go to this website, which actually, when I checked it last night, is down. The online calculator, if you go to this link, isn't working. But if you just Google ACC risk calculator, you'll be taken to a page that looks like this. It's an online calculator where you can put in some very simple demographics and lab values for your patient. And what you'll get is an estimation based on a massive analysis of pooled data from tens of thousands of patients. You can get someone's predicted 10-year risk of having a first cardiovascular event. It doesn't take very long. It doesn't take a lot of information from the patient. I'm gonna demonstrate it for you now. I'm 52 years old. I'm male. I'm white. My blood pressure, last time I checked, it was a little bit high, 143/84. My cholesterol is not great. It's about 235. My HDL is 48. My LDL is 135. I don't have diabetes. I've never smoked. I don't take any medications, no statin, no antihypertensive, and no aspirin. This calculator will let you follow patients sequentially. So it's asking if I want to use data from a previous visit. I don't. And you get a number. And this is my cardiovascular risk. So I'm in a borderline risk category. My risk of having heart attack, stroke, cardiovascular death in the next 10 years is 6.5%. So that's in the intermediate risk range. My lifetime risk of having a cardiovascular event is 46%, which is kind of frighteningly high. And my optimal risk, if all preventative measures were instituted, would be 2.6%. So that gives you a place to start with your patients. And it gives you a way to target your therapies and what you're recommending to your individual patient. So up to 3% or less is considered low risk. Up to 10%, 10-year risk is considered intermediate risk. 10 to 20% is considered a high risk group, and then greater than 20% very high risk. So it gives you a number to go by. Yes, absolutely.
Okay, this is Dr. Ortega. So one of the limitations that I found, or it's been a kind of a frustration, I love the tool, it helps a lot. but they don't account for family history. And I wonder what your thoughts are about that.
Family history is tough because it's a very heterogeneous factor. So there are some people that have a bad family history, and it's due to some identifiable factor. They're all smokers, or they have either familial hyperlipidemia or just a familial tendency towards high cholesterol, or a strong predisposition to diabetes. But then there are people, there are some lineages where there's tons of coronary disease and there's no identifiable risk factors. So I think in that sense, it's not like hypertension where kind of every moderate hypertensive is similar. There are so many different reasons that people have a family history of coronary disease that it is probably difficult to quantify. So your point is well taken. I think it's just too heterogeneous a factor to put a number to.
And that's kind of what I figured as far as that. But like as far as taking care of patients, should we? I know you can't really put a number to it, but would you sort of keep that in mind as like, let's say you calculate their risk at 6%, but they say like everybody in my family has heart attacks, in their 50s. So I mean,
absolutely. So
that.
Yeah. So absolutely. So when people tell me about the family history, they say, yeah, everybody in my family has heart attacks. I probe them a little bit more and find out why. Were they all smokers? And do you smoke? And sometimes people say, yeah, everybody in all my uncles and my dad had heart attacks and they all smoked. But I've never smoked because I didn't want to follow in their footsteps. So if it's a factor that they can avoid and it's an identifiable risk factor, then I think it matters less. The people who are, I think, much more worrisome are the people who say, yeah, everyone in my family's had heart attacks and, none of them had diabetes, nobody smoked, nobody really knows why. That's one of those as yet undefined risk factors. We lump it as family history, but because we don't have a test for it. But yeah, definitely those people I see as higher risk. And I'll treat it not, you can still calculate their score, but it's sort of almost like a multiplier. I look at it in the same way as I do a calcium score, which I'm going to talk about later, as a risk, maybe a risk adjuster. You could look at it to kind of upgrade what the number you get really means.
Okay, and that was my next question. If maybe in that situation where they're kind of borderline, if maybe a coronary calcium score would be helpful.
Yeah. So if they're borderline, now I'm going to talk a little bit more about calcium score specifically. But yeah, a borderline person who's kind of equivocal about whether they want to institute some active preventative measures, calcium score I think is helpful. But also, I think in many settings is misunderstood. So I definitely want to go into some detail about calcium score. So lifestyle changes. It's easy to get lost in the weeds talking to patients about their diet. People are always asking me what diet should they do. They want to, buy a book or have a diet with a name. And for personal and cultural and preference reasons, diet is not a one size fits all. And what I tell patients is to avoid the bad stuff. I tell them any food you can get without getting out of your car, you probably shouldn't be having. They should avoid heavily processed foods, empty calories in high carb diets, sugary drinks. But I tend to not get into specific dietary recommendations for primary prevention. For folks who have had either struggling with their diet in a primary prevention setting, or for folks who have had a cardiovascular event, I think formal nutrition counseling is helpful. For post-MI patients, often that's done in the setting of a cardiac rehab program. And interestingly, I've worked in a couple of different places from training till now. New Mexicans seem to be extremely attuned to the effects of their diet, and often after a heart attack, family members will ask me not what medicines they're going to be on, or what should they be doing, or what tests are they going to get. They ask what their family member should be eating. So for whatever reason, we culturally in New Mexico have a very high attention to diet. So I think particularly for those people, a referral to a nutritionist can be beneficial. Exercise is a big one. And staying active and staying healthy has obviously a myriad of health benefits. When I ask my patients, almost every visit, I ask them about physical activity, both to gauge what their baseline activity level is, to gauge whether they're having any exertional symptoms, but also to be a nag. A lot of people will exercise because their doctor tells them to, and they're reticent about coming in and not having done their exercise. The most common response I get when I ask people what they've been doing for exercise or how much they exercise is not as much as I should. And that phrase is used probably 80% of the time when I ask the question. But people have different perceptions of what exercise is. I have a group of patients that go to the gym. They have their 3 times a week trip to the gym. That's part of their, social and routine life. But a lot of people hate the gym and they feel like they're not exercising if they're not, in a facility for it. But just going for a walk is what I tell most people who do have a relatively sedentary lifestyle. I think walking is a great form of exercise. It's difficult to have an excuse not to do it outside of orthopedic or mobility problems. But just tell your patients to get out there. I tell them to start slow, start small, walk down the sidewalk for 5 minutes and turn around and walk back, and gradually build it up. I always fear that people who particularly after a cardiovascular event, they try to go all out and realize they hate exercising. They go to the gym for 2 hours a day for a couple of weeks and they say, I hate this, I'm not going to keep it up. But a small, very manageable form of exercise that they maybe enjoy or at least don't hate. But if they're able to maintain that over the long term, I think that's far better than being excessively ambitious and getting to the gym on a regular basis. And then finally, tobacco abstinence. That's something we should be talking about to really any patient. Everybody should be asked about smoking, and more than diet and exercise, getting rid of cigarettes is critical for their mitigating cardiovascular risk. This is a graphic of the time course of the benefit of smoking cessation. You get measurable improvement in biomarkers and endothelial function within weeks and months of smoking cessation, and a measurable decline in cardiovascular risk beginning at a year that really continues over the decades. And there's no other intervention that we have, not taking an aspirin, not taking a statin, not going to the gym, that has this cumulative effect as eliminating smoking from somebody who smokes. And I tell patients that, and that I find that to be one of the more impactful things that they can be told, is that of all of the things we have to offer you, stents, surgery, medicines, testing, the one thing that we can do that is going to that's going to impact your health and your cardiovascular risk the most is smoking cessation. And I think a lot of people feel like, oh, well, I take my pills, it's okay that I still smoke. The cumulative effect, the magnitude of the effect of smoking cessation is greater than anything else that we can do for these patients. So we talked about 3 lifestyle changes: diet, exercise, and getting rid of cigarettes. So what drugs can we use? And we've got a whole host of drugs at our disposal in the field of cardiology and cardiovascular medicine. So what is appropriate and effective for people who don't yet have coronary disease, at least haven't had coronary disease detected? And there are really only 3 types of things that are of proven benefit. So aspirin, statin, and antihypertensive. Through my entire career until last year, aspirin has been the cornerstone of prevention. You know, somebody's got risk factors, they've got a strong family history, aspirin a day, easy thing. You don't need a prescription for it. And that was kind of the mantra for decades. And that has changed in the very recent past, based on an accumulation of clinical trial data that has quantified the benefit of taking aspirin and also quantified the harm of taking aspirin. So what you see in this graphic here is the risk categories for 10-year cardiovascular risk: low, moderate, and high risk patients. And this is their risk of cardiovascular events without aspirin and with aspirin. And you can see there's a slight little drop there, barely perceptible on the graph for low risk patients. Low overall risk, low actual risk reduction. Moderate risk patients have a little bit more of a benefit from aspirin. And like many of the things that we talk about, the higher the risk, the higher the absolute benefit in terms of risk reduction from an intervention. So there's a small drop in risk in the highest risk group, but that's at the cost of bleeding. So these are non-trivial bleeding. So we're not talking about nosebleeds or shaving nicks that bleed, but mostly GI bleeds, some intracranial bleeds, not so much hemorrhagic strokes, but subdural hemorrhages that occur with falls, things like that. There's a small but real increase in risk of bleeding complications with taking a low dose 81 milligram a day aspirin. So you're trading some decline in cardiovascular risk with some increase in significant bleeding. And to put that in some numbers, in low risk patients, and this is just an example, if you took 1,000 40-year-olds at low risk, so less than a 3% or less 10-year risk of cardiovascular event, treated them with an aspirin a day for 10 years, you would prevent 5 heart attacks and you would create 5 significant bleeds. Most commonly, these are bleeding ulcers. So overall effect is small because this is a very low risk population. You're asking them to take a daily medicine, and the overall both benefit and harm is small, but the harm is not inconsequential. If you change that group to intermediate risk and make them a little bit older, so 60-year-olds treated for 10 years, you're going to prevent more heart attacks. You'll prevent 17 MIs, but a proportional increase in significant bleeding. And this is across most age groups, at least less than 70. We're going to talk about older folks in a second here. But the higher the risk of a cardiovascular event, the higher risk of bleeding that you would get when you take aspirin. And that's led to a change in recommendations, but from the U.S. Preventive Services Task Force, as well as ACC/AHA, recommendations changed last year after decades of an aspirin a day keeps the doctor away. The recommendation changed to not use aspirin for routine use for primary prevention purposes. And again, I want to emphasize primary prevention and distinguish that from folks who have already had a cardiovascular event. They're a totally different population. We'll talk more about them in a few minutes. But for primary prevention, don't use aspirin unless someone is at high risk, so greater than 10% 10-year risk, it's suggested that you can, on an individual basis, discuss as a provider, you discuss with the patient their preferences, their fear of cardiovascular disease. This is where family history would come in if they're really apprehensive about cardiovascular risk and don't have any identified risk factors for bleeding. You could consider a prophylactic aspirin in those folks. And that's up to age 70. Ages 70 and above, there's a pretty clear signal for higher bleeding risk. And for primary prevention purposes, it's recommended to not start aspirin in 70 or older patients, even if they are at high cardiovascular risk. So the Preventive Services Task Force made their recommendation. It was April of last year. This is a little bit different from the HA recommendations. So the formal guidelines from the U.S. Preventive Services Task Force was to not use aspirin in 60 years old. If the patient's 60 years or older, do not initiate aspirin. Ages 40 to 59, it can be considered if there's greater than a 10% 10-year cardiovascular risk. And then the next question is, well, what if they're already taking it? And we know less about those people. Folks who have been taking a daily aspirin for a long time and have not had problems have perhaps self-selected themselves as people who are not going to have a bleeding complication. You know, if you're prone to a stomach ulcer from aspirin, you would have had it in the first year or two of taking it. So if you've been taking it for 10 years, it's probably okay to continue. But that's a case where, again, there's no blanket recommendation. It's kind of an individualized decision with the patient and their provider. And I want to distinguish that from secondary cardiovascular prevention. Much higher risk, absolute risk of cardiovascular events in somebody who've already had one. So any previous cardiovascular event, an MI, CABG, stent, any kind of revascularization, they've already had established cardiovascular disease. Those patients should all be on an aspirin a day. Things get complicated if they're on an oral anticoagulant, if they've had DVT or AFib or something like that. That becomes a much more complicated calculus. But if they've had prior stroke from carotid disease, peripheral vascular disease, or any cardiac event, they should be on an aspirin a day. Last year, after that U.S. Preventive Services announcement, there was a lot of stories on the news and newspapers, and I had tons of patients coming in saying, should I stop taking my aspirin now? And those are patients who have had CABG. Those are patients with, 10 coronary stents. They're saying they heard on the news that you're not supposed to take aspirin for coronary disease anymore. And we really need to make it crystal clear amongst ourselves as providers and for patients. We need to be clear the difference between somebody who's in a primary prevention mode versus a secondary prevention mode. And all those secondary prevention patients should continue their aspirin, where if you find that they're not on an aspirin, they should be.
Can I ask another question about that, the coronary calcium scores? And maybe you're going to cover this and you can tell me, I'll get to that later. But so let's say you send a patient, my typical 60-year-old male that has a calculated risk of 20%, absolutely refuses to take statins. So I send him for the coronary calcium score. It agrees with that. And he definitely has some calcification. Would you now consider him as having CAD or not based on that?
So I would. So the guidelines, and we argue back and forth about this, and the guidelines kind of skirt the issue a bit. That person has CAD. They have coronary atherosclerosis. I'm going to skip back a couple of slides. they have this. They're somewhere along the spectrum. So in this slide, these little white things are calcium in the vessel. You've identified them as having coronary artery disease. They haven't had a clinical event, but they have preclinical coronary artery disease. And my own personal opinion is that they should be treated as though they have coronary disease. So I recommend, unless they have a very low cholesterol, I recommend a statin for them. If your guy who's got a high risk and you've proven to him that he's got calcium in his arteries, you can tell him, you've got coronary artery disease. It just hasn't done anything to you yet. And the best thing for that guy to keep him from having his first coronary event is to stabilize his plaques with a statin. And that's another thing I find helpful to talk about with patients, is people are afraid of, the 90% blockages. But like we were saying before, it's more the 30% inflammatory, unstable, vulnerable plaque that's going to cause the sudden heart attack. The explanation and kind of the argument I give to patients is the thing that's going to keep them from having a heart attack is not treating a 90% blockage, but stabilizing their plaque. And that's one thing that statins are effective at doing. And that's why we think they do impart that risk reduction that has been so well studied and so well proven, is that they stabilize. If you look at this bottom left corner, they stabilize the plaque. They reduce inflammation in the plaque. They improve endothelial function and make it less likely for that plaque to rupture. So for your guy, I think that someone who's at high risk but is resistant to taking a statin is exactly the patient in whom a calcium score can be beneficial, both to further solidify his high risk, but also act as leverage to get him to come around to the idea of instituting a preventative therapy.
Now, what about aspirin in that situation?
Aspirin is tougher. I think it's probably beneficial, and somebody who has a high calcium score, I will often tell, if they don't have a bleeding risk, I'll have them start an aspirin. It's not addressed by the formal society recommendations. It's left to be one of those high risk provider discuss with patient and come up with shared decision making.
Okay, thank you.
I think that person is clearly at higher risk than somebody who just has the risk factors and a number coming out of the calculator. Because some of those people, if you scan them, they won't have coronary calcium, and there's some unidentified protective factor that's kept them from having coronary disease. But somebody who has manifest coronary atherosclerosis, I think it makes sense to be on an aspirin unless there's a reason not to. All right, I'm going to skip forward a bit here. Okay, so statins. I think statins really are the best thing that we have if we're going to give someone a drug to reduce their risk of having a coronary event. It's a statin for the mechanism that I just explained, with stabilization of plaque, reduction in risk of plaque rupture, and also slowing of the progression of coronary atherosclerosis. So the non-plaque rupture, gradual deposition of plaque is slowed, not stopped with a statin, but it will slow the progression of atherosclerosis. So both for primary and especially for secondary prevention. This is a figure from the West of Scotland trial, which is one of the initial primary prevention trials of pravastatin for primary prevention. This was back in the late 90s, early 2000s. This trial was done, and was really the first the seminal trial that proved that you could reduce someone's risk of dying. This is death from any cause. So all-cause mortality is a really hard thing to prove that you've impacted. These people died less and had a lot less cardiovascular death with pravastatin used in primary prevention. Over the ensuing couple of decades, there's been hundreds of thousands of patients studied in a gazillion trials, and pretty much every statin trial has shown a reduction in cardiovascular event rate, plus minus reduction in all-cause mortality with statin therapy. And as with aspirin, the magnitude of risk reduction is relative to the absolute risk. So most trials have somewhere in the neighborhood of a 30% relative risk reduction with statin therapy in primary prevention, and that's really irrespective of what the baseline LDL level is. But the absolute risk reduction is very mumuch dependent on their baseline risk. So if you take someone with a 2% 10-year risk and you put them on a statin and reduce them to a 1 point whatever risk, have you really done them a favor? Probably not. But if you take someone with a 15% risk and you take them down to a 10% risk, then you've made a meaningful impact in their health. And I'm going to go back to that calculator at the end here. A nice thing that calculator does, particularly when you're doing patient counseling, is it quantifies the effect of the interventions that you're proposing. So you can say, this is where you're at now. If we do this intervention, this is what your risk will be. And oftentimes seeing the numbers can help people kind of understand why you're doing what you're doing and appreciate the benefit that they may realize. So recommendations, these are the updated preventive task service recommendations from late last year. So for anyone 40 to 75 years old that has greater than a 10% 10-year risk of a cardiovascular event, based on that calculator, statin is recommended. Slightly lower risk, intermediate range, 7.5 to 10%, consider a statin. And again, this is where patient preference comes into play. You wouldn't want to necessarily twist someone's arm into it if they're 45 years old and they've got a 7.5% risk. If it's somebody who says, yeah, doc, I want to do everything I can to not have a heart attack like my grandfather, then prescribe them a statin. If it's somebody who said, I read on the internet that statins kill people and I'm never going to take one, it's probably not worth having that fight. Now, if it's someone with your 20% risk that you mentioned earlier, has a strong indication for a statin, it probably is worth educating that person some more and doing the calcium score and presenting as compelling a preventative argument as you can, because that's the person who will benefit the most from the statin. For older folks greater than 75 years old, there is insufficient data to make a guideline level recommendation for statin use for primary prevention. And then hypertension, antihypertensive drugs in patients who are hypertensive will reduce the risk of their first cardiovascular event. The definitions change over time. They're different for different societies. The most, if you're going to go by one set of numbers, hypertension defined as greater than 130/80. And then again, U.S. Preventive Services Task Force, HA recommendations are to start treating if they're greater than 140/90 for intermediate or lower cardiovascular risk. Start an antihypertensive greater than 130/80 for a 10-year, for a high cardiovascular risk, which is greater than 10% for their 10-year risk. That's pretty aggressive. Honestly, personally, I don't start antihypertensives on people, primary prevention for 130/80. That would be the last thing I would do after getting them improving their diet, doing exercise, get them on a statin. And then if they're really motivated to minimize their risk, adding in an antihypertensive. But that's a pretty aggressive treatment threshold. All right, so coronary calcium scores. So this is, I think, one of first, before we move on, any other, this is a little bit shifting gears. Any other questions from the audience there? Okay, so coronary calcium score is a somewhat useful test. It's a very much misunderstood test, both among providers and among the general public. It's a low dose non-contrast CT that is done for the detection and somewhat the quantification of preclinical CAD. So there's no role for this in somebody who's had a bypass surgery, no role for this for somebody who's had a stent or has had a previous heart attack. This answers the question, do you have coronary disease or not? If you already have coronary disease, then this is a completely irrelevant and useful test. And I have patients who come in who've had work on their arteries done, and they want to get it checked on with a calcium score. And it's misunderstood, but using it in that setting is totally inappropriate. And I always dissuade from that. Coronary calcium score does not provide meaningful anatomic information. I think this is one of the biggest misleading things about the calcium score. When it's being read by the cardiologist or radiologist who's interpreting it, just by mechanism of how they measure it on the screen, they get a score of the LAD, they get a score of the circumflex, they get a score for the right coronary artery, and they add it up and they get the total score. Because those other steps are done, you get a report that has a score for each individual vessel. And that is more often than not interpreted as, oh, I've got a bad LAD because that's where all my calcium is. Calcium in the wall of the vessel does not correlate with luminal stenosis of the vessel. It correlates with overall aggregate risk for coronary events. It does provide the diagnosis of coronary artery disease. It does not tell you whether you have blockages in the arteries. It doesn't tell you if you have flow-limiting lesions. It does not tell you where problems might be in the coronary tree. You can look at it sort of like a cholesterol measurement or smoking status. So somebody with a high calcium score is like somebody who smokes or like somebody who has a very high cholesterol. And although you can get anatomic information from it, it does not provide any meaningful information about risk or what's actually going on in the vessel. So it's looking for, all you're detecting is calcification in the arteries. So healthy artery, non-calcified plaque. None of these things here will show up on a coronary calcium score. You're looking for plaques which have calcium in them. Calcium is formed in some folks as the plaques are forming. More commonly, calcium is deposited in the healing of a subclinical plaque rupture. So it's sort of the later stage of a formation of an atheroma. So it does not correlate with narrowing of the arteries. So here you've got, on the left-hand panel here, you've got a normal calcium score. So that person doesn't have coronary atherosclerosis. That's someone who, if they have I often do this in people who have a family history and no real risk factors identified, and they're afraid they're going to follow in their family's footsteps. I'll get a calcium score, and if they have a calcium score of 0, they may in fact have evaded the family curse of coronary disease, and oftentimes that provides a lot of reassurance. On the other hand, on the right side, you're seeing here outlined, this is aortic calcification here, there's coronary calcification here. That high calcium score means they've got plaque in the arteries. It doesn't tell you whether it's an occlusive plaque, doesn't tell you if it's a vulnerable plaque, it just tells you that they do have the process of coronary atherosclerosis. So it can do a couple of things. It can provide the diagnosis. Does this patient have coronary disease, or does this patient not have coronary disease? You can have non-calcified plaque that's not detected by this, so it doesn't rule out the presence of coronary disease. But what it does is, if there's plaque there, it says, yes, this patient has coronary disease. And it does identify people who are at risk for having coronary events. The higher the calcium score, the higher risk of having a coronary event. So it can provide the diagnosis. So to go back to your patient who had a risk score of 20, you can say, yes, you have risk factors, and look at this picture, you have coronary disease that we should be attending to. Second point is, it can be a tiebreaker when there's uncertainty regarding statin use. Maybe somebody's intermediate risk, they're not sure they want to commit to taking a pill. Get a calcium score, and if it's high, that can be the tiebreaker to say, yeah, I think I want that prescription. And also, as we had mentioned before, it can be one of the factors that you take into account when you're deciding whether you're going to do primary prevention aspirin or not. What you don't want to do is use it for looking for blockages. It's not appropriate for evaluation of symptoms. It should not be used as a rationale for doing further imaging like stress testing, cath, or CTA. It should not be used as a decision to pursue workup for revascularization. And it should not be used for repeat scanning to assess for treatment response for disease progression. These seem relatively straightforward. I actually did a heart cath on a patient this morning who had diabetes, hypertension, hyperlipidemia, which he'd had treated for over a decade. And someone decided to get a coronary calcium score on him. And the question is, to what end? He's already got all of the primary prevention measures in place. Sure enough, he had a high coronary calcium score. So he was sent to a cardiologist, and the cardiologist did a nuclear stress test on him. This guy goes to the gym, exercises to a heart rate of 130 with no symptoms. And sure enough, his exercise stress test had a perfusion abnormality. So he was sent for a cardiac catheterization. I did his coronary angiogram this morning, and he had a chronic occlusion of his proximal LAD that was well collateralized. And now we're down this rabbit hole of pursuing imaging and intervention on this guy who should never have had anything done more than his risk factor modification. We now know he's got coronary disease, but in an asymptomatic patient, there's no benefit from revascularization. So basically, he was subjected to multiple unnecessary tests with the misperception that somehow calcium scoring was going to be able to somehow improve his health outcome. After his catheterization, we actually had him start an aspirin. That was the one thing he hadn't done. And I put him on a low-dose beta blocker because he was a little hypertensive. But it's critical to keep in mind what you're trying to get out of your evaluation, and whether the calcium score is going to add more information above and beyond the baseline risk assessment that you've already done. And don't fall for the trap of drawing too many conclusions from a test that's not designed to do that. And this is something that's happened time and time again, as people have that misperception. And this is the way I look at it. You've got a calcium score of 0 on the left. That's like an old car. All of these things are about 50 or 60 years old. 50-year-old arteries, calcium score of 0 is like this classic muscle car. You don't know the engine's good, but probably things are fine. It's been well taken care of. It looks good. This 50-year-old set of arteries has a calcium score of 1200. Think of that as like a rusty car. You don't know that the engine's bad, but you think it's probably going to be at higher risk for breaking down than the car on the left. But you can't look at this and say, okay, yeah, they're going to need a new transmission, or, oh, the engine block's about to go. It just marks it as being at higher risk for having problems. And I would look at the coronary calcium score as sort of a kick the tires of a car and look to see if it's been well taken care of. It's not going to tell you, you can't look at this patient up here and say, yeah, he has a problem with that artery. It just means he's got essentially wear and tear on his coronaries. Things that you shouldn't do in a primary prevention setting is baseline EKG in an asymptomatic patient. That really doesn't have any value. It's a very non-specific test with low sensitivity and low specificity, likely to lead to excessive, unnecessary, and potentially harmful testing in people who don't need it. A baseline echo just to check on someone's heart in the absence of symptoms is not a helpful thing. And stress testing is often suggested in high-risk patients who have high-risk features and a high risk for having coronary disease. If they're not having symptoms, then there's no reason to go down the road of trying to get them revascularized, because this is a whole nother lecture in and of itself. But revascularization for asymptomatic patients is almost never the right thing to do. You want to medically mitigate their risk, but doing stents or surgery is generally not helpful. And when you're going down this road of non-invasive testing for ischemia, if you're trying to detect silent asymptomatic ischemia with the idea that a procedure or a device is going to improve the patient's health, you're going down the wrong path. And the same thing with coronary CT angiography. In an asymptomatic patient, that's often misleading. And I've done heart catheterizations on people who have been sent because of the results of coronary angiography, CT angiography, where we know what their arteries look like. And if they don't have any symptoms, we know from the get-go before we put a catheter in them that any coronary revascularization will be clinically inappropriate. And if that's the case, there's no reason to take them to the cath lab to begin with. So to go back to the risk calculator, just one other thing I want to point out on it as we're talking about these interventions. I think I just lost it. There was one other feature I was going to show you on it, which I will just describe, is you can you all still see me?
Yes.
All right. You can go back to that calculator and there's some buttons you can click, some radio buttons that will tell you what the risk will be after different interventions are instituted. So as you're counseling a patient, you can say your baseline risk is 8%. And if we start you on a statin, it'll be brought down to 5.2%. And then they can use that information to help decide whether they want to institute the preventative measure that you're recommending. And then lost. Can you guys see my slides? Oh, here we go. Here's that. Here's that calculator. Keeps going away. So there's a tab for therapy impact. So my risk of 6.5%, if I were to start a statin, that risk would go down to 4.9%. If I started a blood pressure medicine, that risk would go down to 3.6% with the statin and blood pressure medicine. So I think that's a easy to understand and useful tool for patients. I wanted to really focus on primary prevention, and I think I've burned all of my time talking about primary prevention. So I'm going to omit things I was going to touch on, which was care of the post-event patient and also what to do in the office for triaging people presenting with symptoms. What I do want to say, I'm going to skip to my final couple of slides here, is to touch on aspirin and P2Y12 inhibitors in secondary prevention patients. So one of the things that comes up in my practice on a daily basis is whether people need to stay on aspirin and Plavix after or aspirin and Brilinta or aspirin and Effient after their PCI. And something that you should always keep in mind with someone who has a heart history is whether they have a stent in an artery. If they do, that is a permanent intravascular foreign body. We typically recommend continuing, if it's an acute coronary syndrome or a ST elevation MI, that they continue dual antiplatelet therapy for a year and then stop either the aspirin or the P2Y12 inhibitor. If it's an elective PCI that is not an acute setting, it's 6 months. And then it gets very complicated if they have a reason for oral anticoagulation. But the point I really want to leave you with regarding this is to not interrupt DAPT in the first 6 months unless they're having some major bleeding. The thing that comes up all the time is somebody needs to have dental work, someone needs a colonoscopy, someone needs knee surgery after having a coronary stent. And I never, unless it's something like a brain tumor dissection, I never have people stop their aspirin for surgery. What can happen when you have a stent in your artery and you undergo surgery, if you withdraw your antiplatelet medications in the setting of surgery, you have, due to cautery and tissue plane disruption and dissection of tissues, you have platelet activation. And somebody just in everyday life could go without aspirin for a week and be fine. If you take that same person and you cut into their abdomen or saw through their femoral head to replace their hip, they're going to have platelet activation. Platelets will stick to that stent even if it's 10 years old and cause acute stent thrombosis. That has somewhere in the order of a 30 to 50% mortality rate, even if it happens in a hospital with a cath lab. And I have seen patients die from liposuction because somebody stopped their aspirin and they had coronary stents. I've seen people die from colon resections, kidney stone extractions, because someone has told them that it's okay to stop their aspirin before they have surgery. So if you guys face that and someone is saying, can I stop my aspirin because they told me to before I get X, Y, or Z done, be sure you know about their coronary artery stent status. And if there's a question, contact their cardiologist, because in most cases, the surgery can be done while taking aspirin, and the hazard is really quite high for stopping it. And there I will conclude, and I'd be happy to take any questions.
I was going to ask one question about the risk reduction. You showed the therapy reduction on the calculator.
Yeah.
Do you know, is that kind of fallen in line with that graph that showed the risk reduction with tobacco cessation? Do you know about how long it takes for that reduction to occur?
Great question. It depends on the intervention. So statins, within a few weeks, statins have been studied in the acute setting, high dose atorvastatin in the setting of acute MI, and it hasn't really been shown to have any incremental benefit. But there is evidence that you get anti-inflammatory effects and plaque stabilization within a very short order, like weeks after starting a statin. You're already getting some benefit. Magnitude over time, I can't tell you. I don't know that that's understood. Blood pressure control is a much flatter curve in terms of benefit over time. You know, with a statin, you're going to have an immediate drop and then some trailing off benefit. blood pressure control is going to be a very gradual decline. And smoking cessation, you saw the graphic. You've got over the first year, you've got the beginnings of benefit, but then that really picks up over time.
Thank you.
Welcome. All right. I think we're out of time. Any other parting questions? All right. Well, thanks you all for your attention today. I hope that was helpful.